Welcome to our presentation on hyaline cartilage and rheumatoid arthritis at the elbow. My name is Kimberly Colbert, and I'm going to be presenting with Erin Hannafin, Ani Nazarian, and Ramon Partida. To introduce our case, Anna is a 45-year-old female who was diagnosed with rheumatoid arthritis 4 months ago. Her chief complaint is pain and discomfort while gripping in the hands and pain in both of her elbows. She reports pain at night along with pain in the morning that usually lasts 1 to 1.5 hours. She has stopped engaging in hobbies and activities of daily living, including general gripping activities, opening jars, brushing her hair, reaching behind her back to hook a bra, and cleaning around the house. The major parts of the past medical history that are important to note here are that she is a smoker and smokes 2 packs a day. Her mom has rheumatoid arthritis, and she has a BMI of 32.
Now I'm going to be talking a little bit about the normal structure of hyaline cartilage. So it's 2 to 4 millimeters thick and it's avascular. So nutrition of the cartilage relies solely on diffusion from the synovial membrane. And this contributes to the limited healing capacity in response to injury. It's also composed of a dense extracellular matrix with highly specialized cells called chondrocytes. And it's composed of water, collagen, and proteoglycans. So the dry weight is mainly composed of collagen type 2, while the fluid weight is mainly composed of water. And proteoglycan turnover can take up to 25 years, and the half-life of collagen is estimated to range from several decades to 400 years, which you can imagine can contribute to its limited replication properties. So there are 4 zones of the ECM. The superficial zone accounts for 10 to 20% of cartilage thickness. It's mainly composed of type 2 and type 9 collagen fibers, which are aligned parallel to the surface of cartilage. They're packed really tightly together, and they contain a high number of flattened and highly dense chondrocytes, which is very important in the protection of the deeper layers. This zone is solely responsible for the tensile properties of cartilage, which enables it to resist shear, tensile, and compressive forces in the joint. The middle zone comprises of 40 to 60% of cartilage thickness, and it contains proteoglycans and thicker collagen fibers. The collagen is mainly organized obliquely, and it's the first line of resistance to compressive forces. The deep zone is 30% of cartilage thickness, and the collagen fibers are arranged perpendicular to the surface. This zone provides the greatest resistance to compressive forces and contains the largest collagen fibers, the highest amount of proteoglycans, and the lowest water concentration. The last zone is the calcified zone, which plays an important role in securing the cartilage to the bone. This anchors the collagen fibers of the deep zone to the bone. So the primary role of articular cartilage is it's essentially connective tissue for diarthrodial joints. So its main function is to provide a smooth, lubricated surface for joint movement. And water provides 65 to 80% of the total weight, and it provides lubrication and the pressurization of water within the ECM. And this really helps the cartilage ability to withstand significant loads. Type 2 collagen represents about 90 to 95% of the collagen in the ECM. And collagen structure is very important. So it has a triple helix structure, which provides the cartilage with shear and tensile properties, helping to stabilize the ECM. And proteoglycans, so aggrecan, which is a type of proteoglycan, is the largest and most abundant in the ECM. And it provides hyaline cartilage with its osmotic properties, which are critical to its ability to resist compressive loads. So the viscoelasticity of the cartilage relies on two types of mechanisms. So you have the flow-dependent and the flow-independent mechanisms. So the flow-dependent mechanism relies on the interstitial fluid. So forces during joint loading causes an immediate increase in the interstitial fluid pressure. So if a deformation exists, fluid flows out of the ECM. And then when the load is removed, the fluid flows back from the inner joint space into the tissue. But the flow-independent mechanism relies on the collagen proteoglycan matrix and negative electrostatic repulsion forces. So aggrecan, which I mentioned earlier, they're negatively charged. So under compression, they're pushed together close in the collagen matrix, and this increases the repulsive force against one another because they're negatively charged. And this really adds to the compressive stiffness of the cartilage.
Now I'm going to go into why rheumatoid arthritis attacks articular cartilage. There are 5 components to every synovial joint: an articular capsule, articular cartilage, their surrounding ligaments, and synovial fluid along with synovial membrane. Synovial fluid and synovial membrane are the 2 important factors that play into rheumatoid arthritis, because rheumatoid arthritis essentially attacks those structures. So RA is a chronic inflammatory disease characterized by chronic inflammation of synovial joints that leads to a progressive destruction of articular and periarticular structures. There is also an extensive infiltration of inflammatory cells into the synovium and the tumor-like proliferation of RA synovial fibroblasts that cause the formation of hyperplastic pannus, which essentially leads to the destruction of underlying cartilage and bone. So you can imagine, as Ani mentioned, there is no longer the protective kind of casing when you have rubbing up the joints. So to rule in a diagnosis of RA, you need an ultrasound or MRI. Ultrasounds allows imaging of synovial proliferation by grayscale, as well as by both active inflammation and neoangiogenesis by Doppler. Ultrasounds do a really good job of identifying bone erosions as well as subclinical synovitis. Other advantages include low cost, its wide availability, lack of contraindications, and it also allows for non-invasive real-time imaging. A disadvantage, however, is it is operator dependent. So you are relying on the technician to know what they're doing and how to take the images. With an MRI, it's a lot more sensitive and detects synovial hypertrophy or pannus formation, like I had mentioned earlier, before the occurrence of bone erosion. Its major disadvantages, however, are its cost and not being able to image multiple joints in one measurement. So things to consider when ruling in a diagnosis of rheumatoid arthritis. Now going into the risk factors for rheumatoid arthritis, most commonly it's present in 40 to 60-year-old adults, more prominent in females compared to males with a 3-to-1 ratio. It's also, regarding family history, it's also genetic, could be X-linked, and hormonal differences are suspected to play a role. More evidence is needed, though, in the connection between genetics and rheumatoid arthritis. And then with BMI, obesity is associated with a higher prevalence of RA in both men and women. With smoking, despite inconsistencies among sources, the risk of RA is increased among smokers compared to non-smokers. And lifelong cigarette smoking is positively associated with the risk of RA, even among smokers with a low lifelong exposure. So any cigarette smoke is going to be harmful to the disease. And then socioeconomic status, rates of RA are higher in people in the lower socioeconomic groups. So all things to consider when looking at who is more predisposed to rheumatoid arthritis.
As Kimmy mentioned, rheumatoid arthritis is a chronic inflammatory disease that is characterized by persistent symmetrical inflammation that occurs to multiple joints and occurs in 1% of the population. People are typically genetically predisposed to this, and there's a chronic onset with patients having typically the listed alleles would be an increased incidence of the disease. RA goes through periods of remission and exacerbations, varying in severity, and the disease will progress primarily attacking synovial joints of small joints first, and then large joints, resulting in disability and deformity of the joints. And severe states can then progress to systemic damage of other organs. The elbow is not the first joint to be affected by rheumatoid arthritis, but it follows in line with the disease progression fairly soon after the interpharyngeal joints. And elbow joint erosions are commonly seen in about 32% of individuals with rheumatoid arthritis. It affects the synovial membranes, resulting in synovitis as the primary abnormality, and later leads to bone erosions and cartilage damage. And with the bone and cartilage of the joints destroyed, it leaves the tendons and ligaments of the elbow weakened, increasing the risk of deformity. And RA is usually a very painful disease for patients, and symptoms can include joint warmth, swelling, redness, limited range of motion, including the morning stiffness, fatigue, tender joints, and sometimes fever and weight loss. And there's also rheumatoid nodules that can form under the skin. So rheumatoid nodules are the most common extra-articular manifestations noted in RA, and approximately 7% of patients will present with nodules at the time of their diagnosis. And these nodules are typically found on the exterior surfaces of areas of repeated pressure or repetitive trauma, most commonly the olecranon and the dorsal aspect of the hand, but it can develop in any tendinous or ligamentous structures like the Achilles or the vocal cords, although it's less likely. And pannus is a hallmark sign of rheumatoid arthritis. It is persistent invasive synovial tissue that ultimately obliterates cartilage, bone, and soft tissue of the affected joint. And synovium is composed of 2 layers, the superficial intima, which is made of 1 to 3 layers and responsible for the flow of joint fluid, and the subintima, which is the joint space. And the normal synovium transforms into invasive pannus, which is thickening in both layers of the synovium. And then the intima is thickened from 1 to 3 layers to 8 to 10 layers. So pannus has destructive properties that essentially eat away at cartilage and then bone. And this aggressively causes synovitis, which will increase the white blood cell response to the area and triggers an autoimmune cascade. And for more information regarding this, I linked a video. Pannus causes damage to the hyaline cartilage of the synovial joints through direct adhesion and invasion. And because hyaline cartilage is avascular, the pannus is destroying it faster than it can regenerate, leading to cell death. The outside-in model refers to the mechanism of hyaline cartilage destruction that is more common, whereas the inside-out model is where bone loss is from the cellular changes to the subchondral bone marrow, which is the layer of bone just below the hyaline cartilage in a joint, which plays an important role in maintaining the homeostasis of weight-bearing joints. And this becomes destroyed with the formation of inflammatory infiltrates, and this destruction of the subchondral bone will eventually result in the degeneration of hyaline cartilage. There are numerous risks beyond bone cartilage destruction in rheumatoid arthritis. It can affect the brain, causing fatigue and reduced cognitive function, lungs by causing inflammatory and fibrotic disease, impairing the exocrine glands, causing severe dryness of the mouth and eyes, and skeletal muscles, causing sarcopenia. And some more severe diseases will cause inflammation of the cornea, small rheumatoid nodules within the lungs, buildup of excess fluids in the lungs, and small vessel vesiculitis, which is inflammation of blood vessels, restricting blood flow and damaging vital organs. Patients with RA are also at a greater risk for kidney and blood cancers. So here are some common red flags for rheumatoid arthritis. I'm not going to go through each individually, but I did highlight some ones that I thought were important. Scanning for cancer with unwanted weight loss. Fever could be a sign of infectious processes in the joints. Neck pain or pain in the back of the head. There was a lot of literature about subluxation of the atlantoaxial joint. And then sudden loss of motor function could be because of tendon rupture. So since we talked about OA extensively in class and it's a more common disease, I want to take the time to differentiate the two diseases. The obvious differentiation is that OA is not an autoimmune condition and has no effects on the lungs, heart, or other organ systems. And the diagnosis of RA can be differentiated further from OA as it affects typically the PIP and MCP joints, whereas OA will typically only affect the DIP joints or primarily. And OA typically affects only one side of the body as opposed to the symmetrical nature of rheumatoid arthritis. And another differentiating factor is the persistent morning stiffness of at least 1 hour or more. Patients with osteoarthritis may also have morning stiffness, but it typically resolves within 20 to 30 minutes. And lastly, the indication for surgery is typically a last resort as a treatment for rheumatoid arthritis after all other non-surgical approaches have failed. And the indications include unrelenting joint pain or functional decline due to joint destruction. And the goal of surgical management is to relieve pain for the patient and restore function in joints.
So joint protection can be an extremely helpful program for the treatment of RA. So the program can include exercises along with proper joint positioning techniques, energy conservation, and the use of orthoses and assistive devices. This can help to reduce joint inflammation, pain, and preserve joint integrity. So ultimately, this results in pain reduction, better joint adherence, reduction in stiffness, and overall better ADL functional ability. And so one study that Hammond, Jefferson, Jones, and Gallagher did was that they included 4 2-hour face-to-face sessions in a home program on joint protection, which resulted in a significant increase in the use of joint protection behaviors after 3 months. And immediately after intervention, increases in grip strength and overall knowledge and self-efficacy were seen.
Okay, so to go into the timeline of rheumatoid arthritis can be detected within the first 2 years of its presentation into the body. It starts off with attacking the smaller joints, so that includes fingers and toes. The degeneration of the bone is first. After the bone has had significant degeneration, it then moves on to the hyaline cartilage, and that's where it begins to destroy it. So as the timeline continues, joint space narrowing is one of the signs of rheumatoid arthritis, and that coordinates with hyaline cartilage degeneration, meaning as joint space begins to narrow, hyaline cartilage, that is a sign of hyaline cartilage degeneration. The longer rheumatoid arthritis progresses, other structures will then become involved. Patients who are experiencing rheumatoid arthritis in the elbow can also evolve ulnar nerve deformities. So this is important to note for our case. And those ulnar nerve deformities include ulnar nerve damage, Bishop's hand, which is flexion of the medial fingers, and muscle atrophy. And there are 4 stages to look into with rheumatoid arthritis. Stage 1 is the early stage of rheumatoid arthritis. Stage 1 shows signs of inflammation, but can be tricky to find with x-rays. Stage 2 is inflammation begins to spread and act on the hyaline cartilage, so a little more notable. Stage 3 is severe rheumatoid arthritis stage, where the start of pannus begins with the synovium, hyaline cartilage breakdown is at a point where bone is exposed in the joint, and x-rays will now be able to show bone breakdown. Stage 4 is the final stage of rheumatoid arthritis, which will include the fusion of bones within the joint space. This will also limit the joint function, and fibrous tissue will begin to form. So with rheumatoid arthritis, there's also grades to look into. So grade 0 to 5, grade 0 being normal conditions, grade 1 being slight abnormality of the joint, and that can be signs of swelling, osteoporosis, or joint space narrowing. Grade 2 is just the increase in those signs, so erosion will happen, more joint space narrowing. Grade 3 is the progression of those signs, so more swelling, osteoporosis, and joint space narrowing compared to grade 2. And then grade 4 will be severe destruction, so erosion will continue, joint space narrowing will increase. And then grade 5 is the final state or final grade where it's the worst of them all, and the original articular surface will disappear, meaning the hyaline cartilage will be gone, and there will be gross bone deformity, and you will also see the fusion of the bones in the joint. Now going into the muscle atrophy, rheumatoid arthritis will cause pain in the joints, and when looking into the elbow, the combination of joint pain and also ulnar nerve damage will limit the joint's use and ultimately result in stiffened joints, decreased muscle use, which will eventually be turned into muscle atrophy, and the loss of strength. So looking into hyaline cartilage repair, as mentioned before, hyaline cartilage is avascular due to its position where it's found, and that means that it cannot repair itself. There is no known way to repair hyaline cartilage, although tests are still being done, and the earlier you can detect rheumatoid arthritis, the more effective treatment will be to prolong the progression of the disease. Going into medication, disease-modifying anti-rheumatic drugs, also known as DMARDs, is the first line of treatment, and it won't reverse the damage being caused, but it'll slow down the progression of the disease. And there's two main types of DMARDs, that's conventional synthetic, also known as CS, and biological DMARDs, which is proven to be 16.5% more effective than CS and in maintaining the joint's integrity and function. And the use of DMARDs has had cases of bone regeneration, although it is very small percentage of it happening and is not expected. With DMARD, methotrexate is the most common one used. It is often combined with corticosteroids as a pain reliever, and hyaluronic acid and autologous platelet-rich plasma or other intra-articular injections used to treat rheumatoid arthritis to slow down the progression of the disease. So going into surgical approaches, microfractures and drilling is a very cost-effective and simple way, which deals with disruption of the bone and the cartilage to then have the body replace the tissue with cartilage-like tissues, and it is very effective for small joints. Mosaic chondroplasty is a way to plug the disrupted cartilage by taking other parts of cartilage from different parts of the body and using that to repair the damaged cartilage. Challenges with this include tissue availability, which is extremely notable or important to note for rheumatoid arthritis, as there's already limited healthy tissue in the body as it does spread throughout the body. And immune response is a challenge, and keeping in the cartilage surface even is also very important, as its main function is to allow the joints to move smoothly. Autologous chondrocyte implantation, also known as ACI, involves harvesting small pieces of patient's cartilage and taking it to a lab to then grow more of that cartilage and to then inject it into the affected area. And the challenges with this will include cost and the invasiveness of harvesting the patient's cartilage. matrix-induced autologous chondrocyte implantation, MACI, is very similar, except there is the introduction of scaffold to reinforce the chondrocytes that were made in the lab and then put on the affected cartilage. And this is proven to have a better outcome after 5 years compared to microfracture procedure. So to return to normal function, restoration of hyaline cartilage is not possible. As mentioned earlier, instead, the main focus is to slow down the progression of rheumatoid arthritis. And ways to slow that down is high intensity training, adherence to medication, regular physical activity is also important to maintain joint function, and aerobic exercises and dance can also help mental health of patients and slowing down the disease progression. There's still work to be done. However, it is very hopeful that one day we will be able to restore patients' function dealing with rheumatoid arthritis. But as of now, joint replacements are the closest solution to restore the patient's normal function. Here are references. Thank you for attending our presentation on rheumatoid arthritis and the effects of hyaline cartilage.